It's lovely to be with you again. And I feel that so many of you here at the meeting know as much about the training program for NIDCAP as I do, that any of you could give this information. There is some variety among our understanding and provision of NIDCAP training, but for the most part, it follows a very standardized approach. And much of the information can be found on the NIDCAP website, which is www.nidcap.org. I am a NIDCAP master trainer and becoming an A assessment of preterm infant behavior trainer. Dr. All sends her regrets that she was unable to be with us today, but would love to have been here. I want to the remarks that I have to make to remind us that we really want to provide support for parents and infants, but ultimately the hospital should become the setting that supports not only the emerging capabilities of the infant, but also attends to and nourishes the emerging parent-infant relationship. As most of you know, the NIDCAP approach is based on the synective theory of development, which includes a lot of very important developmental constructs in terms of how the individual human infant develops. And as we follow the infant up through early childhood and even into adulthood, many of these theoretical underpinnings are very true for all of us as humans emerging into our ecological niche, and we become more and more differentiated in our capabilities. So the diagram here looks at the integration and the interplay between autonomic or physiologic activity, the motor responses, state organization, social interaction, and self-regulatory strategies, and how the infant develops organization at each level of development in the face of incoming information from the environment and from the caregiving. The one thing that is unique, I believe, about the NIDCAP work is, yes, it focuses on infant communication. It focuses on support of the parent relationship in the NICU. It integrates the family system, and being a grandmother, I just had a grandbaby born in August, and he landed in the NICU, and I wish they had had NIDCAP training. But the NIDCAP work works with the family system within the NICU and the hospital, and then tries to organize a change of systems in order to support the ongoing work of developmentally supportive neuroprotective care. So the NIDCAP is focused on a behavioral assessment of the infant's communication, which is a guide to how we all interact with the babies, whether it's nurses, doctors, therapists, parents. So there's a detailed observation and recording of the behavior of the baby, the integration of the medical and the family history, including the mother's health and mental health history, determining the infant's goals for communication and interaction. And sometimes that's difficult with a very fragile baby to know, how do we determine what is this baby's striving to become more organized at a different level? And how do we support that organization of development at the next differentiated level? We want to be able to collaborate with the family and the NICU staff, that is the NIDCAP professional, to interpret the baby's communication and to do regularly scheduled observations as this baby develops and change the way we individualize that baby's plan of care depending on their medical and developmental communication. Now, the NIDCAP studies, the NIDCAP approach has probably been the most solidly studied neuroprotective intervention that there is. There are many of you in this room who have done the studies integrating the NIDCAP approach into your research. There are phase lag designs, there are randomized control designs, and there are other designs. And I won't go through a lot of the outcomes, but you already heard Petra talking about the differences in the baby's brain structure and function as a result of being in the experimental group. And also the behavior at 42 weeks of these babies is more sophisticated. So there are a lot of outcomes that have been measured, both short and long term. There are better cognitive scores, better motor development scores, better performance intelligence, more attentive mother-infant interaction. And by the way, this is the little girl that you saw just a minute ago, born at 24 weeks at a year of age. And here she is then at about 10. So what we're now finding, and Petra did mention this, is that there are longer-term outcomes from the initial studies of NIDCAP, of the very low birth weight, and also now studies of the effects of the NIDCAP intervention on babies who were born intrauterine growth retarded. There's better right hemisphere and frontal lobe function and both neuropsychologically and neurophysiologically in these infants. There's continuity between what we saw or Dr. All's group saw, both at 42 weeks and as the babies are growing up into their 8 and 9 year follow-up clinic visits. And the benefits of early individualized developmental care last into school age. I want to just reinforce this kind of outcome studies that Petra mentioned as well. This is looking at the Ray Osterrith, it's a functional outcome in visual spatial, but they also have to recall from memory, and they have to be able to reproduce in a time span what was happening in their initial exposure to this figure. So this is right here a control group, and this is the experimental group, when they're asked to copy this very complex figure. And you can see that the experimental group children were able to copy it much more comprehensively. And then after we put away the thing that they were copying, then they had to recall what it was that they had just copied. And then there's a bit of a delay of 5 or 10 minutes, and they have to then reproduce it. And this to me represents some of how these children aren't able to hold on to things in their memory and then to reproduce them in a visual spatial way. So this is the low-risk preterm babies who are 29 to 33 weeks appropriate gestational age when they were born. And this then represents the babies who have now been studied who have intrauterine growth restriction using the same model. And you can see that this is the experimental group here, and you can see the richness, and then you can see that the children who did not have the intervention really had difficulty with that. So it, to me, gives a visual representation of maybe not the cognitive scores, which don't necessarily give you these fine-tuned outcomes in a functional way. So what population is the NIDCAP approach designed for and have proven efficacy with? Extremely and very low birth weight infants, growing preterm infants. Deborah Buehler did some lovely studies of babies who are a bit older and more stable, and the NIDCAP intervention really showed improvements in those babies who got the intervention. Infants born with intrauterine growth retardation, infants at high risk for later developmental delays, and essentially, when you talk about understanding the communication of the baby and supporting their growth and development from one goal to the next, all infants can benefit for this kind of a perspective. So the organization of the relationship-based training in the NIDCAP model is that training is provided for professionals who work with babies and families in newborn care settings. It's all therapists, it's physicians, it's early education people, even social workers. The choice of trainees is by mutual trainer and NICU evaluation, and is a demonstrated commitment and available support for the trainees to go through this process. It's not a huge group, but these people are meant to be the folks who understand best the approach and who can then ultimately provide consultation in terms of other people understanding more neuroprotective strategies, the individual needs of the infant, and also to help the systems change to support the ongoing work. So there's some considerations for implementation of NIDCAP. First of all, it's not an individual training model. We do train individuals, but it's in the context of the NICU that they function in. So in that light, you're working not only with the trainees, but you're also working with the committees and the leadership and the systems that can make this happen on an ongoing basis. So the first thing they need to do is find out, what are our strengths? Where do we have challenges, and we need to think about ways that we can improve. And the NIDCAP organization has developed scales for evaluating the nursery policies and practices, and they're called the NIDCAP Nursery Criterion Scales, and it's a very effective way of looking very critically of what our strengths and challenges are now and what do we want to aim for. So the next step is developing or determining a good fit with a training center or with an individual trainers. In my experience, most of the people who decide on a particular trainer or training center really think about location. How close is that training center to where we are, and we need them to come to us? And our training is done on site in the hospital. We don't typically have people come to our training centers. The language of the trainer and trainees. And it is a big challenge for those of us who are primarily English speakers to do training through a translator, although it has been done and is very effective. But that is a consideration that I think needs to be taken into consideration. The preferred professional background. Some physicians will relate better to physician trainers, some therapists to therapist trainers, and so forth. And so when I train, a lot of times I get chosen because of my nursing and psychology background. The availability. It is a huge undertaking for a trainer to take on a hospital because it is a commitment of time and energy and effort and a relationship based, and you want to make sure that that trainer has the time free to devote what needs to happen in the training relationship. And it has to be a good fit. So there's a lot of interviewing and emails and telephone calls back and forth before the training is started. There are levels of training and quality control built into the NIDCAP model. First, there is the NIDCAP professional, and I'll tell you how one gets to a professional level. There's a trainer, then there's a master trainer who can bring along whole nurseries to become training centers, and a senior master trainer. And then additionally, there is training in the assessment of term and preterm infant behavior, both the trainers and master trainer. Each of these has quality control built into each of their availability and their practice. So the training program overview. There's initial consultation, just to find out what have you found out about your strengths and your challenges. What trainees have you identified so that you know that they will be there after the training is over, that you know you have an effective leader. There's a one-day lecture that is open to whoever wishes to come, and then a workshop for the trainees. And typically, the training is done in pairs. So there's one day bedside observational practice and discussion, and then a day of discussion, review, feedback to the trainees, committees, leadership, and the administration. And that's where you set the stage for a foundation for later stability. Here's just a schematic of what it can look like with the initial consultation, the bedside demonstration, And then, as is typical in the NBO we just heard, that there's work days, advanced practicum, and so forth, ongoing mentoring and consultation. So these will be in your PowerPoint slides, so I'm not going to go into them in detail. Then there's a reliability day when the certificate is awarded as a NIDCAP professional. There's trainer training available, and it's an agreement with a master trainer with the support from their own NICU leadership, reliability in the assessment of preterm infant behavior, and training and mentoring of 2 additional professionals as they become NIDCAP professionals. The educational opportunities it provides, especially across Europe, are very strong. There is a highly trained and a wonderful system of multilingual NIDCAP trainers in Europe, and there are 9 other international centers. But the ones that you have here represented probably in this room from Sweden, France, and there's also an organization, NIDCAP France, that provides a lot of support for ongoing NIDCAP work. Holland, Belgium, our newest center in Denmark, and in Spain there are 2 training centers. And Norway. Did I miss Norway? Sorry. Always missing something. But this is a representation of photographs of trainers from all over the world, and that number seems to keep increasing. So translation into clinical practice in newborn care settings, from birth and even antenatally. Parents should be partners from the start. The resources include staff support and support for systems change at all levels. There are key core trained teams in each NICU that provide consultation to the rest of the NICU. Their trainers, training centers, and NIDCAP professionals become the resources and the hubs for consultation. There's more momentum in Europe than in other areas of the world, and there are more trainers and master trainers emerging. Financial considerations are difficult because it does take a certain amount of money to get the initial team trained. It depends on the number of trainees and the trainers' fees. And in the United States, we're unable to share those training fees for political reasons. There needs to be system support for the trainee observations because they will do up to 30 observations in order to come to reliability, and they must have protected time for those observations. Environmental modifications is good, but not absolutely necessary. Once a team is developed, there's need for strategies to keep that team going, either positions for developmental specialists or some kind of a formula to make sure that the work is continued, not grant supported. And in the United States, the NIDCAP observations and intervention strategies can generate income. So the cost-benefit analysis really depends on the hospital finances, the time for team consultation, and we have to think about the long-term outcomes factored in. And you saw this slide originally. It's the antenatal investment hypothesis that says that the earlier you start with providing individualized developmental care, the more benefit it is, not only short-term, but also long-term. Family costs, it includes community costs, education costs, and probably on into the teenage and young adult years. So there are many people here who can answer more questions about the NIDCAP work, and I thank you very much, and my little colleague here thanks you as well.